Hello and welcome. It's a great pleasure to be back again with another London Dermatology Centre masterclass, and I'm delighted to have Sean Roberts in the studio with me. We're going to be playing this presentation very shortly, and I should tell you that it is uses AI a lot to generate the video, but it is Sean's clone voice, but the ideas and the presentation are all Sean's. So, Sean, would you like to just say a few words about yourself before we launch into your video?
Yes, certainly, David. So my name is Sean Roberts. I'm a psychotherapist working in private practice in London. I work in the health settings, clinics. So my speciality is within dermatology, within chronic pain, and within gut health. So I've got a wide spectrum of experience going back into the NHS, and now specifically work in private practice. I'm accredited with the BABCP and the ISST in terms of schema therapy and cognitive behavioral therapy. And yes, I hope you enjoy the presentation.
Thanks very much, Sean. Well, I'm going to go straight into launching your video. So the screen go blank for a second.
Hello everyone, and thank you for joining us. My name is Sean Roberts. I'm a psychotherapist accredited with the BABCP and the IST, and I work closely with dermatology teams supporting patients whose skin conditions are closely linked with psychological factors, which, as many of you will know from experience, is actually a very large proportion of cases. Today, I want to introduce you to psychodermatology in practical terms, not theory, not abstract psychology, but how integrating psychological understanding into dermatology care can genuinely improve outcomes for patients, make consultations easier for clinicians, and reduce pressure on clinic. This session is really about joined-up care and how small changes in approach can make a big difference. So let's start with what we actually mean by psychodermatology. Put simply, psychodermatology sits at the intersection of dermatology, psychology, and psychology. It recognizes something clinicians intuitively notice very early in their careers. The skin and the mind are constantly talking to each other. Psychological factors can trigger, worsen, or maintain many skin conditions. But equally, skin disease can have a profound effect on mood, anxiety, confidence, sleep, relationships, and daily functioning. This is especially relevant in primary care. Skin complaints are among the most common consultations, and they're also some of the most frequent repeat attendances. Often what brings patients back isn't just the rash, it's distress, worry, or behaviors that unintentionally keep the condition going. Psychodermatology helps us understand why that happens, and more importantly, what we can do differently in routine consultations to help. So why does this actually matter in everyday practice? A very high proportion of dermatology patients are dealing with significant psychosocial impact from their condition. Sometimes it's embarrassment, sometimes anxiety, sometimes low mood, and sometimes quite severe distress. The important point is that the burden of the condition often isn't proportional to the clinical severity we see, and the relationship works both ways. Skin disease affects mental health, but mental health also affects skin disease through stress responses, sleep disturbance, scratching behaviors, and treatment engagement. When this is recognized early, especially in primary care, we see better adherence to treatment, more satisfied patients, and importantly, improved clinical outcomes. Often the medication hasn't failed. The care approach just hasn't yet addressed the whole condition. So how does this connection actually work? We now understand there are clear neuroimmunological links between the brain and the skin. When a person is under stress, cortisol and other stress mediators are released. That affects immune regulation and, in susceptible individuals, can trigger or worsen flare-ups of conditions like psoriasis, eczema, acne, or alopecia. But then something important happens. The skin condition itself becomes a source of distress. Patients worry about appearance, social reactions, work, relationships, and sleep. That distress increases stress levels further, which then worsens the skin again. A self-perpetuating cycle develops. Emotional stress also affects the skin barrier and healing, which is why some patients don't respond to treatment as we expect. So often, we're not just treating inflammation, we're treating a feedback loop between the mind and the skin. It can also be helpful to think of psychodermatology as a spectrum rather than a single type of patient. At one end, we see conditions that are strongly stress, exacerbated psoriasis, eczema, urticaria, where flares often follow life events, pressure at work, exams, or sleep disruption. Then there are patients whose behavior directly affects the skin, such as compulsive scratching, picking, or hair pulling. These aren't deliberate, they're usually coping responses to anxiety or internal tension. We also see the reverse, people who develop depression, social withdrawal, or significant anxiety because of visible skin disease like acne, vitiligo, or alopecia. And occasionally there are primary psychiatric presentations where the distress is expressed through skin symptoms, different presentations, but all share the same underlying interaction between emotional health and the skin. Let me give you a very typical example. This was a 28-year-old patient with chronic eczema. Medically, the treatment was appropriate, but she kept experiencing significant flare-ups, particularly before exams and stressful deadlines. During assessment, we explored triggers, sleep, coping strategies, and the thoughts she had during flares. What became clear was that anxiety increased scratching, hypervigilance to symptoms, and repeated checking of the skin, which then worsened the inflammation. We worked on stress management, breathing exercises, and mindfulness techniques, but also cognitive strategies, helping her step back from catastrophic thoughts about her skin and reduce unhelpful behaviors. Over time, the flare frequency reduced, but just as importantly, the distress around flares reduced and her quality of life improved. The eczema hadn't just been a dermatology problem, it had been a stress skin cycle. So what difference does this make for you in practice? When psychological factors are addressed, care becomes more holistic. Patients feel heard, not dismissed, and that alone often strengthens the therapeutic relationship. Instead of consultations going round in circles, they become more focused and productive. We also tend to see fewer repeat attendances driven by worry or uncertainty. Patients understand their condition better, engage more with treatment, and follow plans more consistently. Importantly, this can act as early mental health intervention, preventing anxiety, avoidance, or low mood from becoming more entrenched. For clinicians, treatment plans become clearer, consultations less frustrating, and satisfaction improves on both sides. In many cases, referral doesn't add work, it actually reduces clinical pressure while improving outcomes. The most effective way to manage these patients is through an integrated care model. This means the GP, dermatologist, and psychologist are not working separately, but collaboratively, each addressing a different part of the same condition. The skin is treated medically, while the psychological drivers and consequences are treated alongside it. Sometimes relatively brief interventions are enough, motivational interviewing to support treatment adherence, or relaxation and breathing techniques to reduce scratching and physiological arousal. For others, longer-term therapies may be helpful, such as cognitive behavioral approaches to change unhelpful beliefs and behaviors, or occasionally trauma-focused work like EMDR, where past experiences are contributing to ongoing symptoms, and where appropriate pharmacological support such as SSRIs can play a role. The key point is this isn't either dermatology or psychology. It's coordinated care addressing the whole condition. Of course, introducing psychological support isn't always straightforward. Some patients hear the word psychology and worry you're saying the condition isn't real. Stigma around mental health services can be a significant barrier. So how we frame the referral really matters. Cultural beliefs can also play a role, and sometimes gentle psychoeducation, explaining the mind-to-skin connection, is enough to help patients feel validated rather than dismissed. Ironically, anxiety and low mood themselves can reduce engagement. The very patients who would benefit most may struggle with motivation, concentration, or hope that anything will help. Another common barrier is an understandable focus on medical treatments alone, but when patients see psychological care as part of managing a physical condition, acceptance improves considerably. Often it's not resistance, it's reassurance that's needed. From the patient's perspective, the benefits are often very noticeable. Many people with chronic skin conditions begin to define themselves by the condition. Their confidence drops, they avoid social situations, and they can feel constantly on alert for the next flare. When we address the psychological side, self-esteem often improves because the patient regains a sense of control. They also tend to experience better long-term well-being. Even if the condition doesn't disappear completely, it stops dominating their daily life. Perhaps most importantly, patients become better equipped to manage flare-ups. Instead of panic, overchecking, or excessive treatment use, they understand triggers and know how to respond calmly and effectively. We're not only improving the skin, we're improving how the patient lives with the skin. In addition to quality of life improvements, we also see clear clinical benefits. Patients often achieve better symptom control as stress reduces and behaviors like scratching, picking, or overwashing decrease. Inflammation becomes easier to manage and treatments work more effectively. Interestingly, some patients end up needing less medication over time, not because we've withdrawn treatment, but because the triggers maintaining the condition have been addressed. We also commonly see reductions in anxiety and low mood. Many patients have been living in a constant state of worry about their skin, and once that settles, their overall functioning improves. Sleep is another big one. When itching, rumination, and nighttime checking reduce, sleep improves, and better sleep itself supports skin healing. So the benefits are both psychological and genuinely dermatological. One of the most helpful interventions is often simply how we talk to patients. First, it's important to validate both the physical symptoms and the emotional impact. Patients need to know you believe the condition is real and you understand how much it affects their life. What we try to avoid are dismissive phrases like, "it's just stress." Even when stress is involved, that wording can feel minimizing. Instead, I might say, "we know the skin and stress systems are linked, and addressing both can really help control this." Open questions are very useful, asking about sleep, confidence, avoidance, or how much they think about their skin each day. Shared decision-making also helps engagement. When patients understand the plan and feel involved, they are much more likely to follow it and benefit from it. As part of assessment, we also use some structured questionnaires, but these are really just tools to understand impact more clearly. For example, the appearance anxiety inventory helps us identify how much a patient is preoccupied with their skin or appearance. The Dermatology Life Quality Index, the DLQI, is particularly useful because it shows how much the condition affects day-to-day life, not just how it looks clinically. We also use measures like the GAD-7 and PHQ-9 to screen for anxiety and low mood, and the Work and Social Adjustment Scale to understand functioning. These aren't labels, they're guides. They help us target interventions, track progress, and demonstrate improvement in a way both patients and clinicians can see. So a very practical question: when should you consider referral to psychology? We need to consider psychology input where treatments repeatedly fail, and there is a strong psychosocial or behavioral component that seems more complex. Another clue is when symptoms persist despite appropriate medical treatment. If the dermatology is correct but the condition isn't improving as expected, it may be that behavioral or emotional factors are maintaining it. Screening tools can also help. If quality of life scores are high or anxiety and low mood are present, that's often a good indicator. Another sign is poor treatment adherence, not because the patient is unwilling, but because worry, checking, avoidance, or overwhelm interfere with following the plan. You might also see significant distress related to appearance in conditions like acne, alopecia, or vitiligo, or features of body dysmorphic disorder. And very clearly, compulsive skin picking or hair pulling, those nearly always benefit from psychological intervention. Often your clinical intuition is right. If the consultation feels stuck, a psychological component is often present. There are also situations where psychiatry, rather than psychology, is the more appropriate referral. One example is delusional parasitosis, where a patient has a fixed belief of infestation despite medical reassurance. These patients are often very distressed and the symptoms feel completely real to them. So a supportive and careful approach is essential. Another situation is persistent skin sensations, itching, burning, or stinging, without a clear physical explanation, particularly when standard treatments have not helped. And again, significant compulsive behaviors, such as severe skin picking or hair pulling, may require psychiatric support alongside psychological therapy. The aim here isn't to pass the patient on, is to make sure they receive the right level of care for what they're experiencing. When referring, a small amount of specific information can make a big difference to how quickly we can help the patient. It's helpful to include the severity of the skin condition and what treatments have already been tried. Just as important is the level of emotional distress, for example, anxiety, low mood, or excessive worry about the skin. Information about functional impact is very valuable too. Has the patient stopped socializing, missing work or education, or avoiding situations because of their skin? And finally, behavioral patterns, scratching, checking, skin picking, or hair pulling are particularly useful to note. This helps us tailor the intervention from the outset, meaning the patient receives appropriate support more quickly and the care feels joined up rather than fragmented. So to summarize, psychodermatology is not an optional extra. It's really part of comprehensive patient care. Mental health and skin health are closely interconnected, and many of the patients we see in everyday practice sit somewhere along that spectrum. When we recognize this, early consultations become easier, patients feel more understood, and outcomes improve. GPS play a particularly important role. You are often the first professional patients speak to, and a brief acknowledgement of the mind-skin link can be enough to change how a patient understands their condition and engages with treatment. Working together, dermatology, primary care, and psychology, we can support patients more effectively and reduce the cycle of repeat attendances and ongoing distress. Thank you very much for your time, and I hope this has been helpful in thinking about how psychodermatology can fit into your routine clinical work. So to leave you with some key takeaways. First, it's worth actively screening for psychological distress in chronic skin conditions. A simple question about sleep, worry, confidence, or how much the patient thinks about their skin each day can be very revealing. Second, even basic stress management advice can help normalizing the mind-skin link. Encouraging routine sleep and simple coping strategies often improves engagement with treatment. Third, collaboration really matters. Dermatology, primary care, and psychological support work best when they're connected rather than sequential. And finally, the most important point, addressing the mind and the skin together leads to more lasting improvement than treating either in isolation. Thank you again for attending. And I hope this helps you feel more confident recognizing and managing the psychological aspects of dermatology in everyday practice. Before we finish, I just want to signpost one particularly helpful resource. The Centre for Appearance Research at UW Bristol provides excellent information and patient-friendly materials around appearance anxiety, body image concerns, and coping strategies for visible conditions. Many clinicians find it useful to direct patients there, especially those struggling with confidence, social avoidance, or preoccupation with their skin. It can also be reassuring for patients to read that others experience similar difficulties and that there are evidence-based approaches that help. Thank you again for attending and for the work you do supporting patients with chronic skin conditions. I hope today has been useful and practical for your clinical work. So I'd like to finish by opening this up for discussion. A useful question to think about is how could you realistically integrate some of these psychodermatology principles into your everyday GP consultations. It doesn't require long appointments or specialist training, often small changes in wording, a couple of additional questions, or recognizing when to refer can make a meaningful difference. You might already be doing some of this without realizing it. I'm very happy to take questions, whether that's about particular patient types you find challenging, how to introduce the idea of psychological support, or when referral feels appropriate. Please do feel free to share experiences as well. These cases are very common, and discussing them together is often the most helpful part.
Okay, thank you, Sean. I really enjoyed that video presentation. Just to make it clear to the audience, the actual voice over for Sean's presentation was AI generated, but the presentation was all Sean's work. He's the brains behind it. I can't see any comments or questions that are relevant at the moment, but perhaps I could have a start of a 10 with you. As a layperson with very little knowledge about dermatology or psychology, this link between the skin and the brain, it seems a little bit like a chicken or egg situation. Which comes first? Is it more likely that the mental stress is causing the skin condition, or are you finding that primarily people come with a skin condition and that affects their mental health? Any thoughts on that?
Yeah, it's hard to weight it in one way or in one direction or the other, really, more explicitly. I suppose people essentially want to get treatment for their condition, their physical condition, and then it highlights the issues that are going on in terms of, so you're right to think of the trigger being that there's stresses in life that can then cause flare-ups or outbreaks. But as you say, there's such a vicious cycle in terms of the connection that to weight it in one way or the other, I don't think it's necessarily helpful. But it's right that you highlight the fact that it's just ongoing in terms of the distress it causes, and it becomes a vicious loop. I suppose that's the best way of looking at it.
Yeah, a kind of follow-up question to that is about the demographics of people with this, or most severely affected with this brain-skin connection. Just intuitively, it seems to me that the younger generation, particularly teenagers, and the stress of social media
Yes.
that is prevalent seem to affect that demographic more than most people. So, do you find there's a particular age group or demographic that tends to be more affected by it?
Well, I think social media has had a big impact. I think young people have always been concerned about their appearance. I don't think that's a new thing, and I suppose there's certain skin conditions that are more associated with adolescence or late teens than later in life. But I suppose social media has made it more extreme, and then people have become more conscious of appearance and become more anxious, and then that has caused them to respond to any discrepancies or anything that they feel that is different in a more extreme way, and that then again goes into that loop that we've been talking about in terms of the anxiety, the stress, the low mood, which can then obviously lead to behavioural changes around avoidance, which is really obviously want to do is work with young people around their self-esteem and to, I suppose, encourage and develop ways and strategies where they can manage any distress, but also to recognise that actually appearance is only one part of their life, and they can have a more fulfilling life once they start to step away from that sort of cycle of more self-focus and avoidance. Yeah.
Well, we don't have any other questions coming in, but if I can continue the conversation with me, I'm intrigued to understand how you got into your profession. Would you say that you were primarily a psychologist, or primarily your training is in dermatology, or
Oh no,
were you trained
definitely
in a
no.
combination?
Yes, no. Primarily, I'm a psychotherapist, so I developed those skills and experience, and then I've transferred those into the dermatology field through a specific interest and seeing that mind link with the skin very clearly. So and because I'm very interested in working with long-term health conditions, yeah, it's a good fit, and I suppose um, the, the need for psychology is very clear within dermatology, and the psychodermatology field is ever growing and expanding, and there's new studies taking place all the time in terms of making more links and more and more treatment recommendations.
So
Yes.
I'm interested in medical technologies and my involvement through the International Society of Digital Medicine.
Yes.
I'm
Yes.
seeing a lot of devices which are using biofeedback and other kinds of techniques for relaxation and stress management. Um, what do you think that they will play a part, increasingly play a part in the future, technology?
In terms of, I'm sure it will. I'm sure in terms of, I suppose it already does in terms of, allowing people access and to online meditation, and so there's a lot more, accessibility, and that what you're saying is how does that lend itself to more relaxation techniques, or the grounding techniques, CBT and technology have a good relationship, and you can see how those techniques can be enhanced. And it's just accessibility as well, as I was saying, for patients to be able to access and to be able to have a treatment plan, and some of the sort of scripting and all of this is very helpful.
Well, to conclude, because we don't have any more questions, as a kind of call to action, the GPs who are seeing this phenomenon, people with either skin conditions or both skin conditions and anxiety and other mental health issues, how can they get in touch with you? What would you suggest to the GPs, to contact the
Yes,
London Dermatology Centre,
that's
or
it. Yeah, just direct, and they can send the referral through, and then I can um, book an initial appointment directly with the patient. So yes, that's the route. So straight through to the London Dermatology Centre, and then we can respond to that very quickly.
Wonderful. Okay, well, thank you very much, Sean. It's been a great pleasure talking to you today. There's a bit of a time difference between us. It's nearly 2:30 here in Kuala Lumpur. You're in London, so I think I'm getting ready for my bed. So I'm going to close the session down now and just thank you once again for your time and expertise in this session. Thank you.
Thank you, David. Thanks very much.